Hello everyone. So in this video, we are continuing with the hematological disorders in the pediatrics. So the next important essay or the short essay is regarding the thalassemia, or it is also as a short answer also. And it is a definition of this thalassemia which include it is a group of single gene disorders due to defective globin chain production inheritance, and inheritance is autosomal recessive. So the thalassemia is due to defective globin chain production, and the inheritance is autosomal recessive. So it is an autosomal recessive disorder, and the single gene disorder is due to defective globin chain production. And alpha thalassemia, the chromosome 11 is affected, and in the beta thalassemia, the chromosome 16 is affected, and the point mutation is most common, and the most common mutation is 619 BP deletion. Base pair deletion. Then history. So that is all about the thalassemia. It's a autosomal recessive inherited disorder, single gene disorder due to defective globin gene production synthesis. And the alpha thalassemia is due to chromosome 11 is affected. Beta thalassemia chromosome 16 is affected. So that is all regarding the introduction. Then about the prevalence in the India, the mean carrier prevalence is 3.3%, more in the north and central India. There are 22.8 per thousand birth rate of thalassemia in the India. Then about the, so this flow chart is regarding the pathophysiology of the thalassemia. So this should be kept in mind that there will be, so in the pathophysiology, we already told that the disease is due to inadequate beta globin chain production. And the hemoglobin chain, which contains both beta globin and alpha chain. So because of the inadequate beta globin chain production, there will be excess of the alpha chain. And this alpha chain excess form alpha 4 tetramers as unstable products in the RBC, and that causes the RBC destruction when passing through the capillaries, and that causes the splenomegaly. Because of this RBC destruction, there will be splenomegaly and hypersplenism. That is a characteristics of the thalassemia. Then also because of this RBC destruction, there will be anemia will be the then because of this anemia, we have to give the transfusion. Then iron overload will be there, and hepatic fibrosis and cirrhosis, and cardiac abnormality and endocrine abnormality will be there. So that is regarding this basic destruction. Then the alpha chain, which instead of the beta globin chain, which combines with the gamma chain to form the HbF, that is the that is fetal hemoglobin, that is alpha to gamma to chain. Then that is hemoglobin F have the high affinity for the oxygen. That is also results in the tissue hypoxia. There will be, because of that, there will be a growth failure, endocrine complications, and TTI transfusion transmit, that is transmission transmitted infection will be the. Then because of this high affinity for oxygen, there will be increased erythropoietin because of the tissue hypoxia. Then there will be increased ineffective erythropoiesis, and that causes the marrow expansion. So because of this marrow expansion, we will have the certain features suggestive of the thalassemias, like hemolytic facies, the skeletal deformities, then osteopenia, that is a pathological fracture will be there, and hepatosplenomegaly. So that is all regarding the pathophysiology. That is all because of this inadequate beta globin chain production. Because of this beta globin chain production, there will be alpha chain excess that will result in the further pathological changes. That is either it forms alpha to gamma to hemoglobin F, and then that leads to certain features. And also the alpha for tetramers unstable products in the RBC destruction that causes splenomegaly and hypersplenism and anemia, and the resultant features. So that is all regarding the pathophysiology of the thalassemia. Then about the classification of the thalassemia. Depending upon the chain affected, there will be, if the alpha chain is affected, that is called the alpha thalassemia. If the beta chain is affected, it is called the beta thalassemia. If the beta chain is absent, not decreased, if the beta chain is completely absent, it is called the beta zero thalassemia. And if the beta chain is partially absent, it is called the beta plus thalassemia. And double heterozygous states in the case of sickle thalassemia and HBE thalassemia. And these are the, so that is all about the, depending upon the chain effect, these are the classification: alpha thalassemia, beta zero thalassemia, beta plus thalassemia, and double heterozygous states. Then about the spectrum of the beta thalassemia. The beta thalassemia, we have the spectrum, that is syndrome. We have the silent carrier. It is usually asymptomatic, and the hemoglobin pattern is normal, and the gene responsible is one. Then we have thalassemia trait, thalassemia intermediate, and thalassemia major. So we have four syndrome: silent carrier, thalassemia trait, thalassemia intermediate, and thalassemia major. It is here, the silent carrier is asymptomatic, and the thalassemia trait, we have the mild anemia and hypomicrocytic anemia. There will be increased HbA2. But in the case of thalassemia intermediate and thalassemia major, there will be hemoglobin, that is fetal hemoglobin F is increased. Then in this thalassemia intermediate, there will be moderate anemia, needs occasional transfusion. But in the thalassemia major, there will be severe anemia and the blood transfusion dependent. So that is all regarding the spectrum of the beta thalassemia. So that is all regarding the introduction. That is because of the inadequate beta chain synthesis and also autosomal recessive disorder. Then we learned about the pathophysiology. Then we learned about the classification and the spectrum of the beta thalassemia or thalassemia. Then about the clinical features, which depends upon the spectrum of the disease. As we indicate here that in the silent carrier, it is asymptomatic, thalassemia trait and thalassemia intermediate, thalassemia major, there will be mild, moderate, severe anemia respectively. So depending upon the spectrum of disease, there will be clinical features. In the thalassemia major, the anemia is if the hemoglobin value is less than 7. Thalassemia intermediate, the hemoglobin value is less 7 to 10. That is moderate anemia there. And the usual age at presentation of thalassemia major is 5 to 6 months. In the thalassemia intermediate, it is 18 months to 2 years. And the blood transfusion dependency, very much independent in the case of thalassemia major, but its occasional transfusion is needed in the case of thalassemia intermediate. And the splenomegaly is very much evidence in the case of the intermediate, and jaundice is very much in the case of intermediate, and also skeletal change. But the skeletal changes, growth retardation, hemolytic facies, and the skin changes like greenish, bronze pigmentation of skin is most common in the case of the thalassemia major. That is skeletal changes, growth retardation, hemolytic facies, and the skin changes, which are more common in the case of the thalassemia major. Then we have the intercurrent infection, which is present in the case of the major and is present or absent in the case of the intermediate. Then target cells is about 10 to 35% in the case of thalassemia major. And the basophilic stippling is present in both cases, and the nucleated RBC is more in the case of the thalassemia major. So that is all regarding the clinical features. We already told that there will be hemolytic facies will be there because of this bone marrow expansion. These features are present. So hemolytic facies, there will be frontoparietal bossing. There will be bossing of the frontoparietal bone. There will be flat nasal bridge and malar prominence, and malocclusion is also there, or the teeth is there. So these are the hemolytic facies, that is frontoparietal bossing will be there. Then there will be flat nasal bridge, malar prominence, and malocclusion of teeth will be there. So these are the hemolytic facies. It is developed only after 3 years of age and delayed in the well transfused child. Then what are the complications following the thalassemia? So growth retardation because of this anemia and hypoxia, there will be growth retardation, inability to achieve sexual maturity. Life expectancy is reduced around 3 to 4 decades. Most common cause of death is cardiac complications due to the iron overload. Because of this treatment option as iron transfusion, there will be iron overload, and that results in the cardiac complications. And the infections is also very much common. That is hepatitis C, HIV, cytomegalovirus virus, and malaria infection will be more, and hypersplenism is also a complication of thalassemia. So growth retardation and inability to achieve the sexual maturity, life expectancy is reduced, infections and hypersplenism, these are the, and also there will be psychosocial impairment will be the. Then iron overload, that is iron deposition in the endocrine tissue, heart, liver, etc. leads to dysfunction of these organs. In the heart, there will be features like congestive cardiac failure, arrhythmias, and sterile pericarditis because of this iron overload. And T2 weighted MRI can detect cardiac overload before 2D echo shows reduced ejection fraction. And hepatobiliary, we have the gallstones because of this iron overload, coagulopathy, cirrhosis, and the liver biopsy to confirm the hemosiderosis. And in the endocrine, because of this iron overload, have hypopituitarism, hypogonadism, hypoparathyroidism, pancreatitis, and diabetes mellitus, osteopenia, and osteoporosis will be those. So these are the complications of the thalassemia as well as the treatment with the iron transfusion. Then about the differential diagnosis of thalassemia major, we have differential diagnosis splenomegaly with anemia in the infancy as congenital hemolytic anemia, congenital malaria, bone marrow infiltration of this myelofibrosis, osteopetrosis, and the pre-sinusoidal portal hypertension, torch infection. Differential diagnosis of blood transfusion dependent disease are the thalassemia major, aplastic anemia, diamond blackfen anemia, Fanconi's anemia, hereditary spherocytosis till surgery, and the sickle cell anemia in the days when hydroxyurea was not available. Then what are the investigations which are done in the case of the thalassemia? The CBC with the peripheral smear should be done. That is hemoglobin, MCV and MCH is reduced and the red cell width is significantly high in the thalassemia major, suggesting increased degree of the anisocytosis versus moderate increase in the iron deficiency anemia. That is, in the iron deficiency anemia, there will be moderate increase of the red cell bit, but in the case of thalassemia, there will be significantly high, that is 30 to 40%. The reticulocyte count is also low to normal in the thalassemia major. The peripheral smear, there will be marked hypochromia, microcytosis, polychromasia, nucleated RBCs, and isocytosis and poikilocytosis will be there. And the Menser index, that is Menser index, that is MCV by RBC count is less than 30 in the 13 in the thalassemia major, but in the case of iron deficiency anemia, it is greater than 13. So it is a good index to differentiate between the thalassemia major and the iron deficiency anemia. Then we have to go for the hemoglobin electrophoresis. It is a gold standard method. The method is the high performance liquid chromatography and also microcolumn chromatography. And we have to take X-ray skull for the bony changes due to the extramedullary erythropoiesis. Because of the bone marrow expansion, hair on end appearance or crew cut appearance will be, that is hair on end appearance and crew cut appearance due to the widening of the diploid spaces of skull, as skull is a flat bone. Then also we have thin cortex of long bones with the widening of medulla. So these are the features, that is hair on end appearance, so the crew cut appearance and thin cortex of long bone, which are the X-ray findings in the case of thalassemia. So then we have the screening test like high performance liquid chromatography or hemoglobin electrophoresis antenatally. Then previously Nestos test is also used. So these are the then investigations for the iron overload is also looked for. That is ferritin we have to look, that is greater than 1000 microgram per deciliter is an indication for the chelation therapy. Heart or bone or liver T2 MRI we have to look for. Cardiac T2 MRI is the only method to accurately access cardiac or iron overload. 2D echo shows abnormality very late in the course of disease. So then also we have to look for the liver iron concentration of the liver biopsy. Then investigation for the patients on annihilation therapy, CBC, urine protein, RFT and LFT. So these are all regarding the investigation, that is CBC with the peripheral smear, hemoglobin electrophoresis, X-ray skull, screening test, and also investigation for the iron overload. Then monitoring of the thalassemia patients for the complications annually in every visit we have to look for the, that is if a patient is confirmed with thalassemia patient, and in every visit we have to look for the CBC height and weight to assess for the growth retardation. 3 to 6 monthly we have to look for the ferritin, LFT, RFT, sexual maturity rating and LH and FSH, estradiol or the testosterone. Yearly we have to look for the HbS-AG, HCV, to look for any transfusion associated infection will be there. So ECG, echo, cardiac MRI to rule out any iron overload. So bone age, DEXA scan. So all these should be done in the case of monitoring of the thalassemia patients. Then what are the treatment options for the thalassemia? The treatment is, the principle is we have to give the packed cell red cell transfusion, management of the complications, causative treatment and future treatment. Then life with and without treatment. If the patient is untreated, the patient should be died by 3 to 4 years. If the transfusion alone, we have the patient die around 10 to 50 years of age. And if the patient is undergone chelation along with itis screen transfusion, live an almost normal lifespan with improved life quality. Then transfusion therapy, we have to use the packed RBC, which are the cornerstone of treatment. So that is all regarding this treatment. The transfusion therapy is more important in the case of thalassemia major treatment. Aims to improve the anemia, suppress ineffective erythropoiesis to prevent the serious growth, neurological or skeletal complications of thalassemia, to prevent the hepatosplenomegaly hemolytic phases. when to start. That is, if the hemoglobin is less than 7 gram per deciliter, we have to start the blood transfusion. And after this transfusion, we have the development of complication will be there. So the complications following the transfusion therapy is that iron overload, transfusion transmitted infections, and others. Iron overload, which cause serious complications on the heart and the other organs also. And the transmitted infection, we have the disease like hepatitis B, hepatitis C, HIV, malaria, and anti-malarials. Then others like gallstones, leg ulcer, osteopenia, exercise plus calcium bisphosphonate should be required. So these are the complications following the transfusion therapy. So that is all regarding the thalassemia. Then we have a short note regarding the iron chelation therapy. That is also asked as a short note in our university question exam. The iron chelation therapy. Um, Iron overload in the thalassemia major is because of excess GI absorption of iron, lack of excretory mechanism for excess iron in the body, and chronic red cell transfusion. So in this condition, that is iron overload is also happens in the case of thalassemia major. So in this condition, we have to give the iron chelation therapy. Investigation before are serum ferritin or liver biopsy, the MRI and ECG, cardiac T2 MRI to assess the cardiac iron overload. So before beginning the iron chelation therapy, we have to go for these investigations. An indication for the iron chelation therapy is usually started at around 2 years or when 10 transfusions have been given. The cumulative transfusion load of 120 ml per kilogram or greater is required. Is there cumulative if there is any cumulative if there is any cumulative transfusion load of 120 ml per kilogram or greater will be the that is also indication for the iron chelation. Then indicated when serum ferritin is above 1000 microgram per liter, and if the liver iron is greater than 3.2 milligram per gram of dry weight. In these four indications, we have to go for the iron chelation. That is, if the uh, blood transfusion is 10 transfusion is complete, or it is usually started around 2 years. If there is any cumulative transfusion load of 120 ml per kilogram or greater, serum ferritin is above 1000 microgram per liter, liver iron is greater than 3.2 milligram per kilogram of milligram per gram of dry weight. In these four conditions, so these are the indication for the iron chelation therapy. So the aim of the chelation is to keep the serum ferritin less than 1000. So that is the indication. That is the indication and the pre-investigation and the of the iron chelation. And the next is the what are the effect of the iron chelation. Because of this iron overload, we will have different effect on in the case of or the complication in the case of the thalassemia. So the effect of this iron chelation is to promote the growth, decrease the iron overload complications, improve gonadal function, improves endocrine complications. And the chelators used mainly are the desferrioxamine, that is subcutaneous or intramuscularly, deferriprone oral, and deferasirox oral. So that is the chelators which are most commonly used. The most commonly used is desferrioxamine. It is used as the dose of 40 milligram per kilogram per day, intravenously or the subcutaneously, infusion over 8 hours for the 6 nights per week. And the vitamin C 100 milligram daily helps DFO treatment. And it is always used drug. And the specific indication for the use of desferrioxamine is cardiac complication, very high ferritin level during pregnancy and before stem cell transplant. The side effects are the retinal and optic nerve dysfunctions, hearing loss, and growth shunting. Gross stunting. Then, if defibrillin is also used, 75 milligram per kilogram daily, orally, thrice daily with the meals. Left, if it has less efficacy than the desferrioxamine. and its side effects are the arthropathy and granulocytosis. Then we have deferasirox, that is used 30 milligram per kilogram per day orally, once daily dispersible. Then it is orally ingested, highly bioavailable, and side effects are the renal toxicity, elevation of hepatic enzymes, and skin rash. Then about the combination therapy, that is to shuttle the shuttle hypothesis are there, that is using two chelators together for better iron removal. It is have additive and synergistic effects, so we uses the combination therapy. That is, we have to deferriprone mobilizes the intracellular iron and desferrioxamine, which removes it from the body. So these are the combination. So the proposed newer chelators, which are the HBED and desferritoxin. So these are regarding the iron chelation therapy. So we already discussed about the treatment option as the in the case of thalassemia as the iron transfer, the blood transfusion. And another modalities of treatment with thalassemia are the first one. The first one is the hypersplenism and splenectomy. Um, then we have stem cell transplant. That is a curative treatment for the that is hematopoietic stem cell transplant is curative treatment for the thalassemia. The sources for the stem cell transplant are the bone marrow, peripheral blood, and cord blood. And the ideal recipient is patient must be well chelated. Serum ferritin is under strict control, and ideal age is at 2 to 5 years of age. And ideal donor is fully matched related donor or the unrelated donor 6x6 match. The limitation is cost is a major issue. Approximately 12 lakhs is for this stem cell transplant. Then iron overload remains an important cause of morbidity even after the hematopoietic stem cell transplant. And another modality of the treatment in the thalassemia is gene therapy. That is a future of thalassemia management, though will take some time before clinical utility. And also we use the drugs like hydroxyurea and erythropoietin. Then by the so these are the management option for the thalassemia. The first and foremost is the blood transfusion, and the side effect is the iron overload, and other cardiac side effects are there. Then other modality of treatment is the hypersplenism and the splenectomy. And stem cell transplant, that is hematopoietic stem cell transplant. Then we have the gene therapy, drugs like hydroxyurea, erythropoietin. So these are all regarding the treatment for the thalassemia. Then how will you prevent? Uh, Strategies by the mass education of the patient, prevent by the mass education of the peoples, then mass screening of high-risk communities, especially before marriage, the genetic counseling of this positive for the thalassemia. That is, if any of the partner is positive, we have to go for genetic counseling also. These are the preventive methods. That is by the massive education, mass screening of the high-risk communities, especially before marriage, and genetic counseling. Then about the prenatal diagnosis, we have chorionic villus sampling and amniocentesis and fetal blood sampling. The tests are the that is HPLC and DNA analysis available. Then the chorionic villus sampling is the method of choice at 10 to 11 weeks of pregnancy, and amniocentesis at 16th week of pregnancy. Fetal blood sampling, we have alpha or gamma globin chain synthesis ratio above 0.02 to 0.03 in the unaffected fetus. Then every fetus with the two carriers of thalassemia trait, which should be assessed in utero. That is, if every fetus with the two carriers of thalassemia trait should be assessed in utero. Termination is advised if the children is or the fetus is found affected. Newer methods in the future are the pre-implantation diagnosis and pre-conception diagnosis. That is analysis of first polar body of an unfertilized egg. So that is all regarding the thalassemia. The prenatal diagnosis by the chorionic villus sampling, amniocentesis and fetal blood sampling by the HPLC and DNA analysis. And every fetus with the two carriers of thalassemia trait should be assessed in utero. And if it found affected, we have to terminate that pregnancy. So that is all regarding the thalassemia. That is introduction, pathophysiology, classification, investigations, management, that is treatment options. Then about the sickle cell disease, another short essay or the short answer is regarding the sickle cell disease that is most commonly asked in our university exam. The sickle cell disease, it is a group of autosomal recessive disorder that is characterized by the production of the HBS. So the definition, which means it is a autosomal recessive disorder that is characterized by the production of the abnormal hemoglobin, that is HBS. The prevalence in the India is there will be homozygous sickle cell disease, sickle cell anemia, that is heterozygous form, and sickle beta thalassemia will be the epidemiology. It is usually common in the tribal hilly areas. And about the pathophysiology, there will be qualitative. It is a that is the sickle cell anemia is a qualitative hemoglobinopathy. There is no defect in the quantity, but in the thalassemia, there will be decrease in the quantity of the beta chain production. But here, it is a not a quantitative hemoglobinopathy. It is a qualitative hemoglobinopathy in which defect is in the beta chain and alpha chain, which is completely normal. In beta chain, the glutamic acid is replaced by the valine at the sixth position. That is, there will be a point mutation that results in the replacement of glutamic acid by the valine at the sixth position, which causes conformational change in the hemoglobin tetramer. In deoxy state, the hemoglobin S molecules interact with each other, resulting in the sickle shape of the RBC. That is only in the deoxy state, HBS, which takes the shape of the sickle. These sickle cells aggregates in capillaries and which cause mechanical obstruction to the flow of the blood in the capillaries, and also which cause the increased addition of the RBCs, resulting in the inflammation. So that is regarding the pathophysiology. Because of the sickling that will result in the mechanical obstruction of the capillary, it causes increased addition of the RBCs, resulting in the inflammation. And disease can manifest as only if the it is homozygous, that is HBSS, and in the heterozygous individuals it is usually asymptomatic and can only manifest as under stress in the form of crisis like hypoxia and parvo B19 infection. So that is all regarding the pathophysiology of the sickle cell anemia. That is mainly it is a qualitative hemoglobinopathy and is due to the glutamic acid is replaced by the valine at the sixth position, which causes conformational change in hemoglobin tetraploid, and only in the deoxy state it undergoes sickle and causes these obstruction and all. Then about the clinical features, there are huge variations in the manifestation for the sickle cell disease. Broadly, the most patients fall into two extreme categories. That is, first category is the vaso-occlusive crisis, and the second category is the sequestration crisis. In the vaso-occlusive crisis, there will be hand-foot syndrome, that is pain in the small bones of hands and the feet, acute dactylitis. Then we have the avascular necrosis of example head of the femur, painful abdominal crisis, acute chest syndrome is there, stroke in the 6 to 70% of cases, priapism, that is brief or prolonged episode will be the prolonged episode which may lead to impotence. And then there will be retinal infarcts and the sickle cell nephropathy. These are the clinical manifestations under the vaso-occlusive crisis. Then another category is the sequestration crisis. In that, there will be rapid spleen enlargement causing left side abdominal pain and sudden fall of hemoglobin to 2 gram per deciliter, leading to shock and severe anemia. So that is about the sequestration crisis manifestation. Then other presentations are, first one is fever, the second one is aplastic crisis, then hyperhemolytic crisis, splenomegaly and painful crisis. So in fever, the fever in the sickle cell anemia is a medical emergency and has to be treated in the hospital with antibiotics. Infection with encapsulated organism is especially common in the case of this patient presenting with a fever. And infection is common because of the autosplenectomy, that is splenic infarcts lead to dysfunctional spleen. The indication of admission is severely ill patient, temperature greater than 40 degrees Celsius, prolonged CRP, hypotension, dehydration, hemoglobin less than 5 gram per deciliter, leukocytosis, leukopenia, and thrombocytopenia. These are the indication for the admission. Then we have the aplastic crisis, that is severe degree of the anemia because of bone marrow suppression secondary to parvovirus B90. Then other presentation is the hyperhemolytic crisis, severe hemolysis in the peripheral circulation and reticular endothelial system because of abnormality of sickle-shaped cells. Then we have the splenomegaly as other feature, usually small palpable spleen due to microinfarcts, but not in Indians, as SKD is milder in the Indians, but in India, huge splenomegaly is also common with the sickle cell disease. Then about the painful crisis, there will be precipitating factors like physical stress, infection, dehydration, hypoxia, acidosis, exposure to cold and swimming for the prolonged periods, and severity is assessed by the Wong-Baker Facer scale. So that is all regarding the clinical presentation. We have two crises, that is vaso-occlusive crisis and sequestration crisis, and below that there will be the manifestations in each. Then other presentations like fever, aplastic crisis, hyperhemolytic crisis, splenomegaly, and painful crisis. Then about the diagnosis of the sickle cell disease. The newborn screening of high-risk population should be required. That is, we have to do CBC, that is hypochromic microcytic anemia and peripheral smear, which may show sickling. The sickling on peripheral smear, which means greater than 50% of sickle hemoglobin content and a homozygous trait. And we have to high performance liquid chromatography is a diagnostic, and HBS in sickle cell anemia, which may be as high as 90%, HBFS, HBAS, etc., which may show the combination of sickle cell disease and thalassemia. Manifestation of both are less severe in such cases. Increased HBF, that is HBF is alpha to gamma 2, and sickle cell disease is beta chain defect. So we have to go for the CBC and HPLC, and the sickling test, which also we have to done. That is RBC, which are exposed to certain agents which precipitate sickling, and MRI, MR angiography or venography for the stroke patients, and the transcranial Doppler to assess the blood velocity in the case of cerebral artery. So these are the investigational treatment, that is CBC, HPLC, sickling test, and the MRI or the MR angiography or the venography in for the stroke patients in the case of the sickle cell disease. Then about the treatment, we have to go for the blood transfusion, increases oxygen saturation, reverses the sickling process, and which relieves the obstruction. Because of this relieving of the sickling process, there will be relieve the obstruction to the microcirculation. Then it is the first line of treatment. That is, blood transfusion is the first line of treatment in the sickle cell disease as well as the thalassemia, and it reduces severity of the splenic sequestration, acute chest syndrome, and aplastic crisis. Risk of alloimmunization is very high in the case of blood transfusion. Then also we have to go for iron chelation in the case of iron overload. Then we have to go for drug of choice is hydroxyurea. It is a myelosuppressive agent which decreases the frequency of painful episodes and the need for blood transfusion, which increases the fetal hemoglobin. 50 milligram per kilogram per day is used as a dose. It increases 5 milligram every 2 weeks to maintain the hemoglobin maximum 10 gram percentage. And we have to stop this hydroxyurea if the hemoglobin is greater than 11 gram percentage. Otherwise, we have to use lifelong hydroxyurea. And also we have to supplement zinc 10 milligram to increases the RBC lifespan. And we have to supplement also folate, and we have to go for stem cell transplant as the curative treatment. So these are the treatment options for the sickle cell disease, that is blood transfusion, iron chelation, hydroxyurea, zinc supplementation, folate supplementation, and stem cell transplantation. Then about the management of complication, we know that there will be complications like painful crisis, avascular necrosis of the femur head, priapism, stroke, and acute chest syndrome. For the painful crisis, in the case of mild painful crisis, we have to give ibuprofen, naproxen, and PCM. Severe, we have to give ketorolac, meperidine. Vasodilation, we have to give pentoxifylline to increase the microvascular circulation. And we have to give comfort measures like heating blanket, relaxation techniques, and massage. And for the avascular necrosis of femur head, we have to give opioids for the acute pain. For the priapism, in the acute, we have to give supportive measures like a hot shower, short aerobic exercise, and pain medication. In the case of prolonged priapism, we have to give the blood aspiration from the corpora cavernosa. That is followed by the irrigation with the dilute epinephrine. Then for the stroke, we have to go for oxygen support, blood transfusion, and exchange transfusion to reduce the HBS to less than 13%, less than 30%. In the case of acute chest syndrome, for the as a complication, we have to manage it as we have to give the oxygen supplementation, blood transfusion, antibiotics, chest physiotherapy, and the pain management. So that is all regarding the management of the or treatment of the sickle cell disease. That is, we have to go for this treatment, and also we have to manage the complications also. Then about the prevention, we have to go for genetic counseling, avoid marriage between the homozygous and heterozygous, penicillin prophylaxis till 5 years of age, vaccine. We have to give the pneumococcal conjugate vaccine, Haemophilus influenza type B vaccine, hepatitis B vaccine 0, 1, and 6 every 5 years booster, typhoid vaccine, meningococcal vaccine. So vaccination and penicillin prophylaxis and genetic counseling helps to prevent the occurrence of the sickle cell disease. So that is all regarding the hematological disorders in the case of pediatrics. So thank you.